Thank you very much for having me. I appreciate you inviting an internist to spend some time with you, and I hope this will be helpful. And I think what you'll see is a lot of the challenges you're facing, or when I was a previous program director are facing, are really much the same. Obviously, you do such important work in your procedural work, but we're going to talk about some of the other stuff today as well. Just real quickly, these are my disclosures. Before I get into the meat of my talk, I do want to thank you. We're well aware at the ACGME just how difficult this pandemic has been on the training community. The mural on the left is quite profound. This was created by Mexican artists. These are pictures of 198 healthcare workers who died early in the COVID pandemic. And unfortunately, the last year and a half, as things began to shift, we saw a lot of the problems of misinformation, COVID denial, vaccine hesitancy and denial, and so forth. And so you on the front lines have often been the brunt of a lot of hostility. And again, thank you for sticking with it and helping folks. I can also tell you that unfortunately, we know of at least 6 residents who died from COVID, and we know of over 70 faculty that have died from COVID. So this has really had a profound impact across the GME community. I'd like to start with a case. I think it's always important to kind of ground our work, as even in education, around patients. I'm going to talk about Charles. Charles is an 83-year-old PhD trained mechanical engineer who's still working when he suffers an acute extensive large bowel infarction due to an incarceration. Had a piece of bowel get caught and a scar and a bit of a hernia. Despite 2 operations, delirium, and a week-long ICU stay, he is successfully transferred to the medical ward under the care of rotating hospitalists for continued recovery, physical therapy, and therapy for swallowing dysfunction. Unfortunately, multiple medical misadventures ensue. There's a delayed diagnosis of hospital-acquired pneumonia, delayed diagnosis and treatment of pseudogout, greatly retards his ability to do physical therapy, is a stage 3 acute ulcer, poor coordination between multiple physicians, and repeated handoff errors. He is ultimately discharged to a rehab facility where additional errors occur, including a trip back to the ER that was unnecessary and so forth. Charles unfortunately loses ground, is discharged from the rehab center to home under hospice care, where he dies 8 days after discharge. One of the things I'd like you to do as we go through this talk is to reflect. Have you ever experienced poor or unsafe care with a family member or yourself? Have you ever witnessed poor or unsafe care being a healthcare professional? And finally, and probably the most important thing for today, what is the role of the medical education system in improving care for patients like Charles? How can we be part of the solution to continually improve care on behalf of the patients and public that we serve? The other thing that's important is that we know that there's still a lot of work to be done. This is a really provocative article from Makari and Daniel. Makari is actually a surgeon. They did a review, and based on their review of multiple studies, they concluded back in 2016 that medical error was the 3rd leading cause of death in the United States. And there is some data to back that up. Obviously, this is quite provocative. This actually made the lay press. And they also pointed out that the majority of errors never show up on a death certificate. Charles' course started with a diagnostic error in the emergency department 3 weeks earlier. It actually showed up with the same symptoms, but was sent home. It resolved kind of spontaneously. They weren't sure what was going on, and he did not arrange follow-up until, unfortunately, he showed back up in the emergency department 3 weeks later. And part of this is what we kind of know as our healthcare system is problematic. This is an interesting study from Commonwealth. As you know, they published data on how we do as a system. And one of the ones that's more sobering to me is this is what's called avoidable mortality, or mortality amenable to healthcare. And they looked at the progress made among these like countries. These are all westernized democracies over the period from 2009 to 2019. As you can see, that the amount of progress made in the US prior to the pandemic, we only saw a 5% reduction. Whereas you can see in most of the other countries, they saw substantial reductions in avoidable mortality during that time. So the question is, how can we, using outcomes-based medical education, address these challenges? And so first, let's start with the definition. What do we mean by outcomes-based medical education? We kind of throw that around, but it's pretty straightforward. This is a nice article from Ron Harden, who's one of the leaders. Jim and I both recently saw him at a meeting. But the central tenet is you start with the end in mind. You focus on what type of physician will be produced and for what purpose, who they will serve. That requires that educational outcomes be clearly and unambiguously specified. You have to know what the end looks like. You have to define it. because these educational outcomes will determine what your curriculum looks like, the assessments that get used, and also what the learning environment needs to be to support that professional development. And so the other thing to keep in mind is, again, who we're really trying to serve. This is a really important article. This was sponsored by the Lancet as part of what they call the Lancet Commission. The lead author is Julio Frank, whose background is a physician, but mostly public health. He's currently the president at the University of Miami. And what they point out in this article from 2010 is that in the previous century, we put a heavy focus on improving curriculum, which made sense. You go back to Flexner, it was kind of crazy. It was the Wild West, as you might say. And so this focus on curriculum and the kind of creation of the 2+2 medical school is really the predominant form in the 20th century. And you may or may not write educational objectives, and then you perform some assessment. In the 20th century, what was the predominant focus of assessment, and how was that assessment conducted? Anybody? Medical knowledge, right? And how do we test medical knowledge mostly? We gave a test, right? And we got good at it. Psychometrics is really helpful, but they pointed out that we had it backwards, that we need to start with the health and healthcare needs of the systems we serve, and that should be grounded in the quadruple aim. And then we develop the competencies and define the outcomes from those needs. And lastly, we work to improve the curriculum and assessment, understanding, however, that they're not separate activities, they're highly interdependent. And so as we think about that as where we've been trying to move over the last 20 to 25 years, this is what the pandemic exposed as part of that journey. It highlighted substantial gaps around all of the transitions, very problematic, particularly concerned about the medical school to residency transition. Medical students, as you know, lost out on many experiences, didn't get various assessments. Their residency to fellowship was disrupted, as was the transition to practice. And there are, by the way, toolkits to help with these transitions that were created by the groups you see. We also found further exposed gaps in assessment, and we also saw an exacerbation of implicit and explicit bias and prejudice, both within the assessments occurring of our learners, but also from patients toward many of our learners. The other thing is that our usual proxies for assessment were also significantly altered and disrupted. We depend heavily on volume, X number of procedures, X number of experiences, and the distribution of those experiences. You get X number of rotations. I'm a general internist. The whole theory was that if I needed to learn how to take care of really sick people, I needed to do an ICU rotation. Let's see, how many of those do I need? Let's say 3. We'll pick 3, right? And so you get like 3 months of that. Those rotations all went away or got disrupted. Folks are redeployed into other things. And even high stakes exams got terribly disrupted. The clinical skills exam completely went away. Step 1's going to pass fail and so forth. And as you can see on the right-hand side there, the way we educated also changed. It got much more virtual. Some of that's actually, I think, a really good thing, but some of it obviously has limitations. And as I said, many of our learners were, redeployed into areas like the ICU or taking care of very sick COVID patients. Now, what's interesting, you might know who this guy is, or is part of this. The state of affairs pre-pandemic weren't exactly great. This is an article that Jim was involved with, and this actually surveyed graduating surgery residents about their perceived self-efficacy in performing these procedures. And for some of them, they felt like they were pretty comfortable. Again, this is self-assessment, so we know that there's some issues with that, but nonetheless, this is helpful. And you'll notice that I've put in the box there that the laparoscopic right hemicolectomy, this is a laparoscopic, only 26% felt comfortable. It is important to know that Charles' surgeon was 8 months out of their general surgery program, and it ended up being an open procedure. And so it's interesting to think that have a lot of folks, residents are telling us they don't feel ready to do this type of procedures. And here's part of our challenge. This is wonderful work from down in Southern California from the late James Bruno and Robert Bork, who's still active. This concept of confidence-based learning, how important it is. So that self-efficacy is important, because what we're shooting for, particularly with our learners in the room, is the upper right-hand box. We want you to attain mastery, not just competent, but mastery. And we want you to be confident you can do that. That's called right action. It's interesting that those who are actually competent can actually do things well, but lack confidence, they're called hesitators. And it's not necessarily a good thing. They tend to delay or take more time than might be necessary. For example, if I'm sitting on a gurney and I'm having crushing chest pain and one of my former residents sees me, and you have it ST segment elevations of 10 millimeters, I don't want them to go like, yeah, maybe we should get another troponin. Maybe we should repeat the EKG now. Like, no, please get me to the cath lab, right? The ones on the bottom are uninformed and paralyzed. They're low in both. And we worry about the ones in the upper left, right? They're confident, but they actually don't have sufficient levels of competence to be able to act on it. It's also sometimes known as the Kruger and Dunning effect, unskilled and unaware of it. So, a couple observations we'll start with. One is the professional self-regulatory system is only as good as what happens in the program and the sponsoring institution. That's you here at Stanford. I call it the reverse Vegas rule. What happens here will not stay here. It will go with you. We know this. And so this system is very important in how it's designed and operated. This is the assessment system. I work on the right-hand side of that diagram. I'm in the accreditation oval, and our primary unit of analysis is the program. And the bottom oval is the certification and credentialing functions, where the primary analysis is the individual. And combined, we form what's known as the professional self-regulatory system. And that's a privilege, by the way. Welcome back. I hope. So in order to really move competency-based medical education forward, we need to really attend to several components. And so I'm going to share with you the core components framework, because I think it'll be really helpful as you think about redesigning your programs. This is the model created by Lane Van Mellen International Group. And essentially, it is grounded in on these kind of 5 components. At the center, you need to have an outcomes-based competency framework. That's absolutely essential. And those competencies have to be sequenced progressively. In other words, we've got to design programs that can tailor the learning experiences, make sure our instruction is competency-focused and also EPA-focused moving forward, and supported by programmatic assessment. And that's obviously grounded in your local context and the culture in which this is operating. And it also is going to be buffeted by what the community and societal needs are. But these 5 components are really important. And I would argue that that progressive sequencing and tailoring has been difficult for us. It's a lot easier just to throw a bunch of rotations together because it's just efficient. But it may not align well with where your learner is developmentally. And so the other thing that's really important about the core components framework are these philosophical principles. And the most important is that it's grounded in a reform growth mindset, which I think is very apropos for being at Stanford because of Carol Dweck, who spent years studying this concept of growth mindset. And a lot of that is embedded in this model. This mindset's really important because it forms the basis for significantly redesigning assessment practices, instructional methods, and learning experiences. It is also focused on promoting learner growth and development through frequent formative assessment. Right? I'm just curious for the residents, when I say the word assessment, how many of you get a warm, fuzzy feeling? I did not see any hands go up, right? It's unfortunate because as we'll see, assessment's critical to professional development and reaching expertise. And that assessment's important because without good assessment, we cannot provide the rich feedback and coaching that is individualized to the learner and grounded in the desired competencies. And then finally, we have to design programs that provide rich and diverse learning experiences steeped in clinical practice where learners can stay as long as required. Now, some actually in a pure CBE model can accelerate, but others need more time. And by the way, that is perfectly okay. Unfortunately, in our culture, it's a problem. When I was in the Navy, we extended a number of folks because there's nothing more disastrous than sticking somebody who's unprepared on an aircraft carrier in the middle of the Pacific. And so we kept them longer, no big deal. And guess what? They all did just fine. We're going to have to rethink the way we approach our variable learning trajectories. And why competencies? Well, remember, competency frameworks are simply that. They're a framework or organizational scaffolding to guide curriculum and assessment. They help us build shared mental models, those educational outcomes in descriptive terms. But it's important to recognize they don't represent the totality of a discipline or all professional development. There's a lot of white space. That's where your mentors here at the program, Mary, Jim, and others are critical to fill in that white space. The EPAs that you'll be working with do not represent the totality of surgery either. These are core components or core frameworks to make sure we're attending to at least the bulk of what it is you need to be able to do as a surgeon. So the other observation then, if you think about the core components framework and its elements, is that residency and fellowship is an intensely developmental process. So let's design assessment programs that support this developmental process. This is what the competencies, the milestones, and EPAs are designed to help with. This is what a real learning curve looks like. This is a wonderful article from Martin Pusick. I strongly recommend it. But learning curves aren't a nice 45-degree incline. They're not a stepwise function. They are sigmoidal. So all of you who are residents, can I see a show of hands? Who's a resident in the room? Awesome. That's what you're experiencing. Does that feel about right? Does it feel like you're just always learning and just, it's amazing what's coming in such a quick period of time? But that's what you're experiencing right now. You are moving out of medical school where you were an advanced beginner, competent in a few things, to moving toward proficiency and expertise. And you're on the steep part of the curve during that time. And so the competencies are really meant to support that. And our goal for you, using the kind of stage model development, is to at least proficiency by the time you finish here at Stanford. But you'll also notice that even if you reach proficiency, you're not done. There's a lot of work to be done to get toward expertise, particularly becoming a deliberate expert. And that deliberate expert requires something called deliberate practice. This is wonderful work from the late Anders Ericsson. We sadly lost suddenly in the spring of 2020. He was an icon, giant, in kind of studying how people develop expertise. But he defined deliberate practice as individualized training activities, especially designed by a coach or teacher, to improve specific aspects of an individual's performance through repetition and successive refinement. Sound like the operating theory, maybe? Working with people like Jim and your faculty? What's important, however, that it requires a field that's reasonably well developed, which means you have to have clear mental representations of the task of that field, or in other words, shared mental models. And that can be a bit of a problem. Sometimes those mental models among us can vary. Some of the variation's okay, but some of it probably isn't. So this is something we have to attend to. And then finally, a really important concept that I hope we continue to embrace a bit more, and this is work by Bill McGahey and others, is mastery-based learning. Mastery-based learning is the floor, is not competent, it's mastery. In this mindset, excellence is expected and achievable while learners are able, motivated, and work hard. Here's what's different. There's little to no variation in outcomes. You've defined what the standard is, and you help everybody to get to it. And they've learned that learning in any domain depends on learning a sequence of less complex components. Again, I think surgery does that much better. I'm a general internist. We didn't break things down in a way to help people build toward a more holistic synthetic performance. And what they've shown, and Bill McGahey and Jeff Barsick and others at Northwestern have clearly shown that if learners receive the optimal quality of instruction and the learning time required, the majority of learners will reach mastery. For example, they've actually shown by using a mastery-based simulation technique for things like central lines, thoracentesis, they dramatically drop complications for patients in the hospital, right? And they weren't allowed to touch patients until they did. Some took 15, 20 cycles, some took 50. As Bill said to me, so what, right? You get them to mastery, that's the goal. If those folks are motivated to do that and they just need more time to get the skills, then that's what we're gonna do to get them there. And this is why. This is wonderful work by Bob Sedlak, who's been studying this for a number of years. And basically what Bob has found overall, that the learning curve for colonoscopy, particularly the ability to pick up lesions and polyps effectively, requires, you can see, well over 300 to do that. In fact, his range, in looking at it from a mastery perspective, was anywhere from 200 to 650. And the point here is you want to get them to proficiency and expertise. As somebody who just had a screening colonoscopy, I hope that's not too much information. Nonetheless, I was really happy that the person who was doing mine was experienced, right? Because it matters. And you have to, attend to these things and make sure people have enough experience, but train to a standard, not just numbers. And this is nice work from Brian George. He's doing incredible work at the University of Michigan. He's the creator of the Simple app. And what he found was that, when he looked at his Simple data, at the time of graduation of all these surgical residents, 97% were deemed competent using the Simple tool. But about 80% were competent in partial colectomy, going back to what I just showed you earlier. Now, these are folks using the Simple app. And so you can see there's this variability, and there's different learning curves for these. Part of this depends on volume, but part of it just depends on having the right coaching and practice to make sure they're learning the right skills. So how do we operationalize development? Okay, we've been talking about the curves are different. We need to tailor things. Well, that's where milestones and EPAs come in. So this is the typical milestone. This is one from surgery in your 2.0 set. This is interpersonal communication skills. There's the 3 levels, but I want to make just a couple points when you're using these. First, we want you to focus on the narrative. Those numbers in the columns are nothing more than a code. That's it. They're just a way to code so we can put it in statistical programs, and that helps us. They do not relate in any way, shape, or form to your PGY level. Some of you might be actually advanced and could be level 3 to 4 very early. Good for you. Some of you may need more practice to do this. This is a complex skill. But when you're working with these, and when your clinical competency committees are working with these, we want you to focus on the narrative, because that's what matters. And then once you've determined where you think they are developmentally, then you assign a code. And remember, level 4 is the recommended graduated target. Proficiency, it is not a mandate or requirement. Milestones are deliberately designed to be more formative, not summative. We want it to be used as part of a CQI model. The EPAs will be more summative, and that way they'll be complementary, which I actually think will be a good thing. And so milestones, again, help us integrate curriculum and assessment. They help guide us on that learning curve. And guess what? Just like what I showed you with Brian George and colonoscopy and other things, these are what we see when we look at the milestones data nationally. Now, these are not nearly as elegant trajectories because we're getting data every 6 months, but you'll notice that there are lots of different patterns to this data. And this is an interesting work we started back when the milestones are first released, looking at trajectories within emergency medicine residents. And for this particular competency, which interestingly, by the way, is wound management, something I think is probably pretty important to emergency medicine doc, 20% were not judged to have reached proficiency at the time of graduation in this first round. And so it's absolutely wonderful that folks are being honest on what they're reporting. And our hope is that we can then use this to generate data to provide feedback into programs so they can identify folks earlier for the purpose of helping them. That's the reason for the system. We're not trying to weed people out here. We're trying to create signals so we can identify folks so we can intervene and help them attain proficiency in wound management, which is going to be critical to their career as an emergency medicine doc. This is another interesting study from our statistician. This is called a caterpillar plot. This is from Kenji Yamazaki. This is from family medicine work we've been doing. And you can see, again, the distributions based on the kind of aggregate. This is the kind of mean of all the milestones, varies greatly by programs. Some of this is going to be due to leniency error. Some might be due to severity error, but you can see there's a lot of variation by program and a lot of variation within many programs. Again, this is actually a bit of a healthy sign the system's working to some degree. It's far from perfect, I totally get that. But what we're seeing is that you'll notice in the circles, particularly those in lower end, those are called outliers. Those are folks who are really struggling. And some of these programs have outliers that are below level 3 at the time of graduation. Making the point one more time that our goal is to identify these folks and help them. And so you can see this variability is very much part of our system. And what we're trying to do by using things like milestones and EPAs is address that and provide guidance for our learners. And so that brings us to trust, right? Which is really what's foundational to the EPA concept. This is a really nice article from Ola Tenkat, recommended if you haven't had a chance to read it. But I think reading this definition is worth a moment. As Ola points out, trust involves the confident expectation that a person, in this case a learner in our system, can be relied on to honor implied or established commitments to an individual, in this case you, the faculty, and protect the individual's interest. The other person that we're protecting here is the patient, because it renders the individual vulnerable, in this case the faculty and patient, to the extent she or he cannot oversee or control the actions of the other, and whose expertise or integrity she or he may depend. And so this system really relies on trust that, for example, if you're taking overnight call and you're really encountering a patient that you're just not sure what's going on, the system relies on you calling your faculty member to run that by them and say, hey, you know, I'm not quite sure what's going on here. Need some help, right? That's trust. Your faculty make trust all the time when they adjust how much they allow you to do in the operating room, right? That's a form of trust. And so this has been codified or operationalized by OLA as something called the Entrustable Professional Activity, which is just simply the routine professional activities of physicians based on their specialty and subspecialty. What I think is most helpful about this concept is this issue of entrustability. And entrustable means that practitioners demonstrate the necessary knowledge, skills, and attitudes. I would insert competencies there to be trusted to perform this activity unsupervised, right? That when you're ready to go out into the world, you no longer need that kind of ongoing supervision, that you're self-directed and you're self-regulated and you're reflective and you're able to move toward deliberate expertise on your own, tapping into your resources and your peers to do that. And so as a result, Ola and his colleagues added trust to the top of what's known as the Miller Pyramid. These are just ways of codifying assessments where knows and knows how is kind of really looking at knowledge through things like multiple choice exams and oral exams, shows how is using simulation, right? Standardized patients, partial task trainers and stuff. I know that you have a wonderful sim center here at Stanford. But ultimately, we want to know what you can do in practice. And so that's why residency is so important, because the majority of time should be spent caring for patients under the watchful eye, coaching, and feedback from your faculty and others, so that you can be trusted when you graduate. And the way we put the system together, this is an example from Ola. This is one example. This is an EPA. And I think Ola was quite proficient, or actually prescient, rather. He talked about providing telephone advice. This was pre-pandemic when he created this figure, so he must have known the pandemic was coming. But he points out, and I'm going to make this point several times, you'll notice that even in this EPA, all the competencies are important. It's not that none of them don't apply. They all apply. But if you wanted to focus on the assessment piece of it, you might target a couple that are particularly important. In this case, he's targeted medical knowledge, communication skills, and practice-based learning and improvement. And what the milestones have allowed us to do, and some specialists have already done this, is that you can actually work across the row and take those narratives I just showed you. And then if you want to write a story for what somebody should look like at the end of training, you can move down the level 4 column or proficiency, and you've now written a little vignette. Why is that important, and why are we working on that? Well, it turns out that when faculty try to match learners to a vignette that's written more narrative, they're actually more accurate and discriminating than trying to pick a number. And so that's why the milestones will kind of serve as the substrate to think about the EPAs. Obviously, they won't be all of the EPAs, but this is kind of work that some are doing, particularly in pediatrics. And the other thing I really want to emphasize is that please don't forget the other competencies. They matter a lot. And so I'm going back to Charles. And so let's say, in this case, we decide to look at this through the lens of EPA 7, which is an acute abdomen. That's what he had when he showed up in the ER the second time. And so he shows up in the ER, a whole series of activities are initiated, and you can see that underneath there are critical competencies needed at that moment. Patient care, medical knowledge, like what's going on, what's the diagnosis. Practice-based learning and improvement, in this case, might be evidence-based practice. He's come back now for the second time. So the question is, why has he come back? Do we miss something, right? Do we need to think about, do we need to look something up? And then he gets into the OR, right, where he has his colectomy, and he's into the ICU afterwards, in the hospital ward, and then ultimately discharged. And if those processes or handoffs don't go well, that's the HO, complications can ensue, and they can then regress back, right? They have to go back to the OR, or they have to go back to the ICU, or they may be readmitted. And along each way, all these competencies are involved. And it has to be undergirded always by professionalism, good communication skills, particularly interprofessional teamwork, and practice-based learning too, which is reflective practice, learning from what happened during this case. So you can see that something like this in EPA 7 is actually quite complex. Now, we may decide to focus assessments on a limit of competence that's perfectly appropriate. But from a teaching curriculum development point of view, all of these come into play. And it's important to keep that in mind. So as I said, rating scales are nothing more than a code. If the code lacks validity and accuracy, it has reduced value for professional development. I really like entrustment scales. We use them. They're now part of our assessment course, but they don't fix what I call the frame of reference problem. What do I mean by that? Well, these are the entrustment scales. You're probably familiar with the O score. The Swiss scale is what's used in the Simple app. These basically are two types. One is how much supervision the faculty has to provide. or how much they had to participate or contribute to the case. There's two forms of these, and they're very helpful. So these are the kind of scales we use. But here's the frame of reference problem. Several studies demonstrate that faculty heavily use self as the frame of reference in judging competence and entrustment. And therefore, assessment assumes self is competent. Like I said, I'm okay with that, if that's true. But what's also important is that the faculty, or if they're using self, is they have to be able to break it down for the learner as part of their feedback and coaching, right? They have to be able to unpack it so the learner understands why this is the best way to do something. And you would think that's relatively straightforward. Well, it turns out it's not. There are several studies. I chose one from surgery. This is an interesting work out of Canada from Apramian and colleagues. What they did is they took a procedure, in this case, a laparoscopic nephrectomy, and they sat down with 11 surgeons and they said, okay, what we'd like you to do is tell us what aspects of the procedure are kind of non-negotiable. In other words, these are key principles to this procedure and you really need to do it this way. And then what are kind of what they called optional preferences? They're kind of idiosyncratic. There might be meaningful differences in surgeons, but you know what? It doesn't matter because it both ways get you to a good outcome. And so you can pick the best path. Maybe it's using a slightly different instrument or something along those lines. And so they had them agree to this, and then they showed them video clips of the procedure and had them say whether it was a principle or preference. How do you think that went? Not well. Although they agreed on that, they couldn't agree on the application once they saw the videos. And so what they found was what is a principle for one surgeon may well be a preference for another. And their point was that because of this variability among the faculty, it creates some challenges for the learner trying to do the sense making around that. So if one person's saying it's a principle, another saying, well, yeah, no, it's fine if you do it this way, the learner is the one that's got to try to make sense of that. That can be really hard if they don't have the skills to do that. And there was wide variability in what was deemed inconsequential preference. So I think this is part of a challenge, but this is true across all professions. We see this in internal medicine and other fields as well. And the other problem with frame of reference is the competent piece. This is work I did with Jen Kogan. We did this some years ago. We had 44 general internists, and I want to make it clear from the outset, they volunteered to be part of the study. They cared deeply about what they did. The average years of experience was 12 years of precept in the outpatient clinic. We had them watch a series of videos and then do think alouds and have them watch 2 live standardized patient resident encounters. But prior to doing that in the afternoon to look at the rating behaviors, we had them undergo an 8-station standardized patient exam in the morning. We stripped out anything that wasn't a key feature of the case so that we didn't get into stuff that wouldn't be necessary for somebody who's a practicing physician. Well, you can see the range of performance on the screen. And if self is the frame of reference, this is a challenge. To the credit of all of these folks, when we debriefed them at the end of the day, they themselves said, like, you know, I got to be honest with you, in some of these areas, I'm just really uncomfortable. One area that came up quite a lot at this time, this is 2010, remember, was breaking bad news with one of the stations. How do you break bad news to somebody around a really difficult diagnosis? Most of them did not know how to do that. They said they'd never been formally watched. They'd never been formally taught. Many were not even aware that there's research around them, frameworks that were available, something called like spikes. And so it just goes to show you that many things that we experience during a training, guilty is charged, we're now being asked to judge, rate, and teach, and yet we may not have been formally trained. And so the aha for Jen and I, and what we've been doing since, is like, how can we make training and assessment a twofer? Introduce folks to help them with their skills. And so in our phase 2 study, that's exactly what we did. And we heard from them that actually it helped them. Some folks actually found that it made big differences in their practice. The other problem with entrustment scales is that they don't necessarily correlate well with what's happening at the point of care. So this is a really important study from Dan Schumacher. And what Dan did is that he had supervisors provide an entrustment rating to pediatric residents rotating through the emergency department when they saw children with one of these 3 conditions. They then performed a medical record audit to look at the quality of care delivered to that child. Only one showed a statistical significance between the entrustment rating and the actual quality of care, and that was asthma. But the beta coefficient you see is only 0.03, which means you can only explain 3% of the variance in the care provided to that child. For closed head injury and bronchiolitis, there was no relationship. And so the entrustment had no relationship to the care the child received. part of the reason this happened was that most of the time they made an entrustment rating is that they actually had not watched the care, nor had they looked at the chart. It was all based on their sign up, what they said was happening in the room. Okay. Again, medicine does that in spades. This is the study we just completed. As part of it, this was meant to be a longitudinal asynchronous type training program to improve direct observation. And based on, we had them watch 10 videos in random order. And these were scripted. Jen Kogan did an amazing job putting these together. So we knew the answer to the performance. And we had them at level 2, 3, and 4 in entrustment. So 2 is they need direct observation. 3 is they need indirect ongoing work. And level 4 is that they're proficient, ready for practice. And what was interesting is that when they rated these videotapes, if the performance was really good, most folks got that right with regards to the entrustment. Makes sense because, and they often said, it's like, yeah, that's better than what I usually see. As the performance got worse, the accuracy also declined. In fact, by the time we got down to level 2, it was basically a coin flip as to whether or not they got an accurate entrustment rating. And the majority of time, the ratings were higher than they should have been. They were overly lenient. And so the point here is that entrustment skills, I think, are much more comfortable. They're easier to use, but they're going to need work and training. And this is actually where you, the residents, come in. That makes sure that you're pushing your faculty for good feedback and say, hey, okay, where do you think I am and why? So we can calibrate. And so I think we have work to do around the entrustment scales that we'll be using. We use them, by the way, in the Milestones work, but also particularly with VPAs. All right, so moving forward, back to Charles. He's my dad. And I have to be honest, you know, it was a really difficult experience. It ended up being about a 93-day ordeal. And there were parts of his care that were actually really good. Let's go back to the young surgeon. She actually was one of the better parts of his care. I have no idea how things went in the operating room, but there were no surgical complications with regard to wound infections, leaks, stuff like that. That seemed to have gone pretty well. The other thing that really impressed me about her is that when we met the next day, he'd had his first procedure. They left him open to go back and make sure he still have ischemia and then closed him up the next day. We're sitting there with my brother and sister, and she says, well, do you want to explain this to them? I said, no, you're the physician. You should do that. I'm not the expert here. And she did a phenomenal job. She took a piece of paper out. She drew out exactly what had happened, why he had gotten incarcerated. And then she laid out what the possible trajectories might be for him in the coming days. And I really appreciated that. And I really appreciated it. And I told her, I said, you know, your communication skills are really strong. And I watched her interact with the team. So that's why I bring this up, because don't forget that other stuff. It not only matters to the folks in front of you, family members, in this case, my brother and sister in particular, but it's also really important to watch her interact with the team within the ICU. The worst part of my dad's care was actually on the medicine service, which was incredibly sobering, you know, for me as a general internist. There were multiple errors, the system failed him, but there were also areas where folks honestly had deficiencies in their skills. And so I think this is something we can do in the medical education system to fix this, right? To attend to those other competencies because they matter. They matter a lot. And so as we think about what the needs are to make CBME effective, these are kind of the big areas. Change management is always an issue, right? Change, you know, we always complain about how hard change is, but you know, if you remember the Greek philosopher Heraclitus, he said, no man steps into the same stream twice. What he meant was, and of course, being in 2000 BC, it would be a man and not a woman, unfortunately. But the only constant is change. And so we have to always be thinking about what's next. And it's also important to recognize change is as much about loss. It is about change, right? It's loss of identity. We've done things a certain way. We're comfortable with it. We have an identity in doing it that way. But sometimes we just have to recognize, like, you know what? It may have worked then, or maybe that's the best we could do then, but we're in a different place now. Let me be clear. I loved my medical school and residency. And there's no way on God's green earth I want to go back and repeat it exactly the same way. Right? We're at a different place. And I really wish I'd gotten more than I got with regards to assessment, observation, et cetera. I'm grateful for that training, but I now recognize a lot of flaws in it. And I also worry about some of the design principles that I hurt people not even know it during that time because of the way we set up supervision. I think we're in a much better place, and I'm grateful for that. We need competence in CBME. So faculties and our learners, we need to teach you what this means, how to use it for your professional development. Remember those core components about tailoring your learning, supporting your progressive sequencing. We need you to be partners with us. We need implementation science, knowledge, and skills. We're going to have to change curricula. We need some deep learner engagement. That's through co-production. And time and resources is important. We recognize that's always an issue. So when you think about the assessment process, I encourage you to think about it this way. This is particularly for the faculty, but also for the residents who work with medical students. When you're assessing somebody, start with the narrative description first. Don't start with the scale. Use evidence wherever you can. And the last thing you should do is fill out the scale. And don't forget that feedback part. And always look for an opportunity to minimize bias. At each of the step in the observation, take what we call an equity pause or a bias timeout. For example, am I using gender-laden language? Am I stereotyping? Right? Look for those opportunities. And then the assessment process, I think we have to reshift our thinking. We don't start with the learner, we start with the patient. This is what we teach in our assessment course. We ask, did the patient get safe, effective, equitable, and patient-centered care based on the triple N? We start there, and then we work back during that observation. We ask, how did the trainee perform to meet that particular goal for that patient at that time? What supervision was needed in order to achieve that aim for that patient, and what will be needed moving forward so that we can fill the gap. Right? It's a mindset shift. Start with the patient as the central focus, work back. They're your outcome. And then I think we have to rethink autonomy. This is, again, a nice article from Brian George about how we adjust autonomy over time, but I'd also point out another really important concept in autonomy. It's called relational autonomy, because we're all interconnected and interdependent. Remember, autonomy is socially constructed and is dependent on particular social relationships and power structures. There's no power issues in medicine, Jim, right? Do not? Okay. Which we are embedded. That's just reality. Remember, autonomy requires more than mere freedom from interference. It requires that one's relationships with particular individuals and institutions have to be constituted in a way to give one genuine opportunities for choice. And so I think rethinking autonomy as relational is really important. And I think how we adjust that is something we need to attend to. Because we know from studies that sometimes we're not giving all of you, the learners, enough autonomy. And that's something we're going to have to continue to work on. I think we have to rethink the rotational design. This is a medicine design. You do your clerkships, the witch of the north waves a wand over you. Congratulations, you're a physician. Then you get to come in. This is my field in internal medicine. And then you get nowadays you get attending every week. So you get the one that's really nice. It's helpful and gives you good feedback at the end of the week. Then you get someone's like, yeah, you're doing okay. The kind of feedback like, yeah, you're right where you need to be. By the way, which is completely useless feedback. And then you get somebody that is again helpful, and then you get the crazy person at the end, and somebody waves a wand over you. Congratulations! And as long as nothing bad happens on that rotation, you collect the Lego block and on you move. I do think we need to take a look at this, particularly in my field. I think these rotations can be counterproductive if they're not constructed properly. And then I think we need to move more into what's called co-production. This is something that's gaining a lot of traction in medicine. This is wonderful work by Paul Paulden and others. And it's really about the interdependent work of users and professionals. In this case, the users are learners to design, create, develop, deliver, and assess, and improve the relationships that contribute to the health of populations and individuals, but does the same for teaching. I think much more of our education has to be a co-produced mindset where learners and teachers co-execute, co-plan through civil discourse together. In other words, assessment is something we do with you instead of something we do to you. You got to get out of that mindset. Because remember, assessment's critical for your professional development. And then to end, thorny question, cost. This comes up a lot. Who pays for the cost of fully implementing outcomes-based medical education? I totally understand that. And also a lot of questions come up. Who pays for the cost of a resident that needs more time and training to reach competence? Right? Our system, because of the way GME's finance, makes this difficult. But I think we need to reframe that question. Who pays the cost of a resident fellow who doesn't reach competence? I think we know the answer to that, right? That's just reality. We have folks that go out that just aren't ready. And that's actually not good for anybody, including the learner, by the way. And so a few conclusions. I think outcomes-based medical education really can help to improve both training and healthcare at the same time. I really think that we're making a lot of progress. When I think about where I was 30 years ago, it's messy, it takes time. I think we have the tools and approaches now. We just need the skill and will. When I asked Bill McGahey to summarize in one word what he thought the biggest problem in medical education was, he didn't hesitate for a moment. He said, inertia. He said, Eric, we have good tools. We've known about master-based learning for 50 years, and its effectiveness. We just need to use it. And I think we have to involve our learners more in co-production, right? They need to be our partners. And it's going to be messy. And I just want to assure you, it's going to be okay. It really is. I think this is a really exciting time. And so with that, thank you very much. And happy to take a few questions. I apologize, we lost a little bit of time there, but I think we still have some time for questions, Jim, if you wish.